All right, welcome to tonight's virtual curriculum. I appreciate all the students who've stuck around. This is I think our seventh night doing this, or sixth night doing this. And honestly, for me, as someone in sports, it's been a lot of fun to kind of hang out with my partners who do other things. And so one of my favorite partners of all time is Dr. Frank Shen. The reason why he's one of my favorites is because he actually taught me a whole lot about being a doctor and being in a lot about spine surgery. I spent about 3 years with him during my 10-week block, my PGY-2 years. So I'm still great memories of that, Frank. So tonight we're going to be talking about spine surgery. The spine team's got a couple, as a lecture and a couple of cases they're going to share with us. I may actually ask some of the students some questions about x-rays and whatnot during the cases. And so I hope there'll be some volunteers to read an x-ray or two. Again, nothing too complicated, just to try to get some people talking and generate some conversation. And then after that, what we're going to do is we're going to have Thomas Moran, one of our PGY-2s, just talk a little bit about life outside of Charlottesville. Then we'll wrap it up. Hopefully, again, trying to keep these under an hour. But we could talk about spine for 3 or 4 hours, I think, right, Frank? So without further ado, I'm going to turn the microphone over to Dr. Frank Shen, my partner and good friend. Dr. Shen, thank you.
Thanks, Winston. Can you hear me okay?
I hear you great, my friend.
Perfect. So, let me see if I have control. There we go.
You have complete control.
Great. So really, I want to really thank Winston. I think Dr. Guafmi and Dr. Bachman really embody what I think great resident advocates are. They do all this for the visiting students, and it is only a tip of the iceberg of what they do for our residents. So I don't think you'll find better advocates, and they're excellent. So I want to thank you, Winston, for everything you've done. I'm going to poach about 5 minutes of the hour just to talk about our division, introduce some of the people that are there and what our rotations might look like for the residents. Dr. Li will talk about sort of spondylolisthesis and augment some of the reading you've got. Dr. Bustos will cover a few cases, and then Dr. Moran, as you heard, our PGY-2 will finish up with life outside the hospital. Our faculty is a full complement. There are 5 full-time spine attendings. We have 3 physician assistants who really round out our group, and a nurse practitioner on the floor. So we're very full and a busy division. The trainees, we have 1 spine fellow, 2 residents typically, so 3 trainees. And then on the trauma months, on our spine trauma months, which can be busy, we get a PGY-1, so there are 4 residents. And then there's a research fellow who doesn't do clinical care, but does a lot of research projects. So that's an avenue for med students and residents to work with if they are interested in some of the clinical research. We have that research fellow. We do our outpatients at the spine center, but in the next year or 2, as we transition to Ivy Mountain, we will join orthopedics there. So we'll be part of the musculoskeletal line. We do our surgeries at the main hospital, but we do a few out at the outpatient, predominantly at the main hospital. I'm the division head. I'm really fortunate to have 5 partners, 4 of the partners. Dr. Scheimer is 10 years out. Him and I have been together as partners since he's been here. He is very instrumental, not just in the spine division, but really as a medical center and a big impact and footprint there. He's the medical director of the orthopedic inpatient unit. So not just orthopedic spine patients, but the total joints, the trauma, anybody that goes to the floor, he's the medical director of that unit. He's also part of the OR implant committee, so he's very involved in that as well. He's the consulting spine surgeon for UVA and JMU athletics, so he's very vital to UVA in our division. Dr. Hazanzada, he's been 6 years, I think now. He's an associate tenured professor. He's probably one of the fastest individuals to that position. And he's very impactful for our division because he's the director of the clinical fellowship, he's the director of the research fellowship, and he's the director, co-director of the spine center too, which is the ortho and neurospine center. So he really has a very important role in clinical care and clinical research. He's had a lot of interest, not just being an excellent spine surgeon in deformity, but in clinical trials. And he's had over $2 million in clinical trial research that our division has done through his efforts and focus. Dr. Singla is one of our past fellows. He's about 6 years out as well. He does adult degenerative, but he's also brought back to help augment sort of the pediatric side. And so he also does, along with Dr. Bachman, the Scoleys and Dr. Abel. So he really does adult and pediatric. And if that wasn't enough, he really is driving an interventional section, which I'll talk about briefly. and what our vision is that is. So he's a very important part of our division and what he does. Dr. Li rounds out our clinical surgeons. He was a resident with us. He went away for a year to join Dr. Lenke for his fellowship, and he came back. We were lucky to have him. He's about 3 years out. He has a very busy research basic science lab. He's the director of the Li Research Lab. He has over $3 million in funding in national funding in R01 and NIH studies and R03 and R21. So his research is translation focused, but not just as a basic scientist. He's a phenomenal clinician and surgeon. And he is really driving sort of the navigation and robotics section of spine surgery. So everybody has a very important role, and we work very well together. You couldn't have a division without having great physician assistants. And so they are really the forward-looking group for us. They interface with us and our patients and the patients in the operating room and with the operating room team. We have Rose Tiger, who's been with us 7 years. She's phenomenal. And Sarah Reinders was a hand PA who now joins us as a spine. So she comes with a lot of background in upper extremity and spine care. So she's a great addition. And Megan Watuson is going to join us in October, and she comes with background in both spine and adult recon. So our 3 PAs are phenomenal, and we're lucky to have them, and they keep us on task. Our nurse practitioner is Deborah, and she interfaces with the patient on the floor, and she'll keep working with our PAs to sort of integrate the care for our patients and with the residents across the spectrum of what we do. Just for you guys, you've heard it in various formats throughout the other talks that the other services put together. But for spine, you spend 10 weeks as a PGY-2 and a PGY-4. And on the trauma months, as a first year, you'll spend a month or 2. So you do get some spine care across your whole training, as Dr. Gwathmey said. On average, it comes down to 2.5 or 3 days of clinic and then 2 days in the operating room. As a PGY-2, you'll spend Fridays as a consult when you're on the ortho service for general ortho. So that's a good opportunity early in your career to see other things early on besides just spine. As far as the education, the fellows will rotate every 3 to 4 months to each attending. So that means the other 2 or 3 residents will cover the other 4 attending. So it's very busy. It's a busy service, but at the same time, it's a great opportunity to see a lot of different things, right? You get to see things in consults and on the floors and in the operating room. And on the flip side, because there's 3 or 4 residents to 5 attendings, you're never fighting the fellow for cases. And so it's a one-to-one mentorship in the operating room and in clinic. So it's a great opportunity. Dr. Li will every 10 weeks have a spine cadaver lab with the residents. I think it's a great opportunity for them, for you guys to see, expose the spine, but also use implants. So it's a great place to start to learn. And we do our weekly spine conference where we do indications. And about 10 minutes during that every Thursday, we'll focus some spine OITE questions as well. So we do also try to drill down to some of the things that you need to know for the exam. What do we do? Just the 1, 2 last slides. We do everything every other spine division does in the country, but we go from head to toe and open to minimally invasive. One area we really believe in and we're starting to develop over the last 3 to 4 years is we have an interventional section where we're really starting to now do spinal injections. We do spinal cord stimulators, and we do cement augmentation procedures. So besides open and minimally invasive spine, we are doing all the things that the interventionalists are doing now. So it's a great experience, and it's only going to keep growing. And I think it's important for our residents and fellows to see those things. I think there's going to come a time where there's no point where we didn't realize that spine is doing everything that needs to be done for our patients, both non-operative and operative. We have all the state of the art here. So we do robotics, we do computer navigation, and we have a 3D O-arm in the operating room. We are all very connected with our societies and with our industry. So every new instrumentation or device coming down the road will be here. It's things like augmented and VR, virtual reality spine surgery is actually not far away. And we'll probably be one of the first institutions, if not the first institution in the country, to have our ability to use that with our patients and improve their care, and things such as integrated systems that is really evolving, and we're all part of that. So our division is very active in that regards. I think that's pretty much it. I'm going to turn the forum over to Dr. Li. He's going to talk about spondylolisthesis, and then Dr. Bustos, so later we'll cover some cases. So Dr. Li, if you could, and the floor is yours.
Okay, Dr. Shen, can you stop sharing so I can?
Great overview, Dr. Shen. It's Dr. Chabra here. Thanks for your introduction to the spine service.
Yeah.
Can you all see my screen?
Yes.
Yeah, we can see it.
Okay. So today we're going to talk about lumbar spondylolisthesis. I will cover the definition, lumbar anatomy, classification, etiology, clinical symptoms, treatment options, and new technology. Spondylolisthesis, spondy means the vertebra, and osteolysis, it means a slip. Spondylolysis is a part defect. Spondyloptosis, that means the fall of the L5 vertebrae body into the pelvis and lying anterior to the sacrum. Spondylosis, that means the arthritis of the spine. The pars is the structure between the superior and inferior facet. We commonly use the meridian to classify what degrees of the slip. If the slip is over 100%, that is called spondyloptosis. Another common we use the classification system is based on the etiology. There are 6 categories, and today we are going to focus on the isthmic and the degenerative spondy. Biomechanics playing a very important role in the isthmic spondy. There is no spondy in newborns or the non-ambulatory patient. There is no spondy in the primates. There is a high incidence in the L5 parts compared with other L4 or L3. In the general population, the incidence is about 6%, but in the high-level athlete, the incidence can go up to the 27%. Facet orientation and the trapezium playing a very important role in the degenerative spondy. Patients with the degenerative spondy have more sagittal-oriented facet joint and also more facet joint trapezium. This shows the L5S1 facet joint. You can see the left side is normal joint, but the right side is the sagittal-oriented joint. And this is the L4-5 degenerative spondy. You can see the sagittal-oriented facet joint, L4-5. Degenerative spondy is very common, and the male have isthmic is common in the males. More female have the degenerative spondy. Common level for the isthmic is L5S1. Common level for the degenerative spondy is L4-5. And this is an X-ray of a patient, lateral X-ray and CT scan and MRI of the same patient. You can see the lateral X-ray showed about 40% of the slip, and CT scan reduced to about 30%. And MRI, when the patient lying down for a while, you can see the spondy reduced about to the 20%. That means there's a instability for the patient that causes the low back pain. For the patient with isthmic spondy, they also complain about the leg pain. Usually it's caused by the pars defect. There is a lot of the fiber cartilage tissue compressed on the nerve root of the L5. That's the exiting nerve root of the L5S1. MRI, you can see there is no fat tissue protect the nerve root like a L4-5 level. There's severe stenosis in the L5S1 neuroforaminal area. Back pain is caused by the instability from the degenerative spondy. You can see the gravity partially reduce the splittage. And the leg pain for the degenerative spondy usually is caused by the central or the lateral recess stenosis. That is compressed on the traversing nerve root of the L5. If we talk about the spondy, we have to talk about the Scotty dog. The eyes of the Scotty dog is a pedicle, and the nose is a transverse process. Ears is the superior facet, and the foreleg is the inferior facet. Between the superior and inferior facet, the neck is a pars. If the neck is broken, that will cause a spondylolisthesis. Flexion and extension X-ray can show whether there is instability. MRI will define where is the stenosis. Is the central stenosis, lateral recess stenosis, or it is the neuroforaminal stenosis. CT scan can show us the facet orientation. The treatment for the spondy, the first line is still the conservative treatment, including anti-inflammatory medicine, agent, physical therapy, or steroid injection. Indication for surgery is the slip progression, high slip causing the sagittal imbalance, neurological deficit including the weakness or numbness, radicular pain and low back pain, which is unresponsive to the conservative treatment. Surgical treatment is directly targeted at the pain generator, either is from the nerve or from the instability. The mainstay treatment is the decompression for the nerve subcompression or fusion surgery for the instability. There's different methods to fuse the spine, either posterior fusion with or without instrumentation, or ALIF, PLIF, TLIF, or OLIF. Different approach to the disc. When we do the posterior fusion without instrumentation, we decodifiy the transverse process and lay some of the autograft and the allograft in that area to fuse the spine. This is a patient with a degenerative slip, and we fuse the spine with the pedicle screws and rod without interbody. This is a patient with a degenerative slip too. We did the ALIF first and then flipped the patient and did the posterior spine fusion. This is a patient with the posterior lumbar interbody fusion. This is a patient with the isthmic spondy. We did the TLIF for this patient. We reduced the slip. There is still a lot of the controversial topic, like for the low-grade slip, whether we do the decompression only or do the decompression with the fusion. For the high-grade slip, we still debate whether to reduce the slip or not, and what approach to fuse the spine, which is the best. And also, we should do the MS surgery or the open surgery. And with the popular of the MS surgery, we can use the tubular approach to put the cage or to decompress. We can tilt the tube and decompress the contralateral side. If you want to do the sports in the spine, you also can do the endoscopic TLIF. You use the different portals and then put in a cage through the tube. And with the popular of the robots, we can design the trajectory of the screws. And we can design the very converged screws, which have the more favorable biomechanical property. In summary, spondylolisthesis is very common. Leg pain is more likely caused by the L5 nerve compression, And the initial treatment is still the non-operative, and surgical surgery is focused on the decompression and stabilization. Thank you.
Great stuff, Joshua. That was outstanding.
Thank you.
So we're going to go on to some cases by Dr. Francis Bustos. Dr. Bustos is our PGY-4 currently in the spine service. And so he's got a couple of cases to go through. And again, we may be asking some questions during this. And so if any students want to, there will be simple things like reading the x-ray and things like that. There's a little hand raise function you can use, and I can actually call on you so you don't have too many people talking at once. So we'll try that this time and see how it works. All right, go for it, guys.
Hey everyone, I'm Francis Bustos, PGY-4 on the spine service. Trying to advance my slide. Gotta take out the pointer. Sorry.
We learned PowerPoint during our PGY-5 year, actually, so we're getting there. There you go.
Work in progress. Here's our first case, 21-year-old female, back pain for 8 months, 10 out of 10, no leg pain. Symptoms are worse with lumbar extension, standing, and walking. She has no weakness and no numbness, no pertinent medical history. She is a non-smoker and works as a zookeeper. Also a student in college, senior. Her height, weight, BMI are listed here. She has no weakness, full strength, can only extend her lumbar spine to neutral. Negative straight leg raise, and she's tender to palpation at the L5 spinous process, maybe even more prominent than the other spinous processes. Her initial x-rays are shown here. I will blow them up, but can we get a hand raise in terms of
any of the students just want to like look at those x-rays? It's pretty simple stuff. Kind of tell me what you see. Let's see if this works. If not, you can unmute yourself and go from there. Yeah, I was worried that there might not be very many takers. How about on this x-ray? Anybody here want to? Well, oh, here you go, Molly. Molly's clapping her hand.
Oh, sorry, I don't know how to actually raise my hand in it.
Again, this is all work in progress. Go ahead. What do you see there, Molly?
So this looks like a lateral x-ray, and I think I see an L5 S1 like spondylolisthesis. Looks like the L5 is anteriorly displaced.
Yeah, good job. What do you think, Francis, or Dr. Shen? Go ahead.
Molly, can you tell me what year and where you're from as well, each person who does raise their hand, just so we know?
Oh, hey, I'm a fourth year at Medical University of South Carolina.
Wonderful, thank you. So what do you think, Molly? How far you said the slip, and that's absolutely correct. Do you have a sense of how much or how you would describe that to us if you were calling us on the phone?
Ooh.
10%?
50%?
Yeah, so it's probably at least 50%. So as Dr. Lee said, that would be like a grade 2, maybe even a grade 3. So nice job, Molly.
Awesome.
Yes, grade 3 spondylolisthesis, L5 on S1. You can calculate a slip angle that kind of shows it there. So she continued to have symptoms despite conservative management. Was seen in clinic follow-up where Scoli films were obtained. This gives us a little more insight into her overall pathology.
Ask a question. Any of the students want to tell me how would you try to measure a curve on a scoliosis film? Anybody know how to measure an angle on this? If anybody has a hand raised, I don't know if we can do that or not. There's Evan Johnson. He's got the actual hand raise.
Hey, this is Evan. I'm a student at the University of Central Florida. So you would do like a Cobb angle. Looks like the patient has a apex right thoracic curve.
Perfect.
Yeah, there's the Cobb angle shown here.
We're getting Dr. Shin excited.
I know. Hey, Evan, what do you think about a scoliosis with a curve to the right? Is that normal or abnormal?
Ooh.
I believe the right curve is the normal one that's more common. If it was a left curve, you'd need like an MRI.
Good job.
Wow.
Whoa.
Very good.
I'm on a ped service right now, so I've been doing this like every day. I don't you know.
Oh, no, Evan, you got to take it and say, you can't say that. You got to say, yeah, you got to take the praise and go with it. You got to run with it.
Might be the only time in 6 years, man.
So other pertinent things of this X-ray, you can see that the scoliosis leaves the shoulders level and the hemipelvis relatively level. On the sagittal, you can look at the vertical axis, the SVA, drawn from the centroid of the C7, a plumb line down, and you can measure to the posterior superior corner of S1. And you see that there's a positive sagittal alignment, about 7 centimeters. The further workup reveals MRI was obtained. And I think we can kind of just go on to explaining some of this case in the interest of time. The MRI essentially showed some degenerative disc disease. We know that she has a good degree of scoliosis, and she had displayed neural foraminal stenosis, most prominently at L4-5 and L5-1. Can anyone tell me what sequence we might be able to see this pathology better?
Let me repeat the question. So what sequence? Oh, we have all right. So, Vaib. Tell me how you pronounce your name, Vaib.
Yeah, it's vibe, like good vibes.
Oh, good vibes. There you go.
No, I wish I could take credit for it. So I think if you were looking for ligamentous pathology with this, a T2 sequence might be better.
So
How about the neuroforaminal stenosis? Which sequence do you see?
Are you talking about sequence like T1, T2, or are you talking about axial versus sagittal versus coronal?
Oh, yeah.
T1, T2.
So neuroforaminal stenosis, my guess would be T1 because you're concerned for, it's more of an anatomic consideration.
Yeah, that's really nice job, Vibe. And I'm sorry, where are you at, Vibe?
Yeah, so I'm a 4th year at Vanderbilt.
Wonderful, great job.
So the reason we use the T1, another reason is because we want to see the fat tissue, right? You can see the fat tissue around the nerve root, but in the L5S1 level, you could not see the fat tissue.
here I'm kind of outlining what we normally see, the fat around the exiting nerve root. Whereas when you get down to L4-5 and 5-1, that space gets obliterated. So here we have, in summary, a 21-year-old female, otherwise healthy. She has scoliosis with a high-grade slip, back and leg pain, and she is a zookeeper. Now, I'd like to ask the attendings for any thoughts on this case.
I want to know where the zoo is. She's a zookeeper. Is there a zoo around here?
Yeah, I think she's actually on what you call a bridge. That zoo at
Oh, okay. The Natural Bridge.
Natural Bridge. Yeah, yeah.
Zoo.
I mean, she's a hardcore. She does. So the point being, she actually lifts 50 to 75 pounds of feed and everything like that. So she's just graduating. She graduated now, but she's a laborer. She's in there every day, 5-7 days a week, doing during the year. It closes down in the winter, but Natural Bridge, which you guys could all visit too if you come to UVA. So there you go.
Well, Dr. Scheimer, Dr. Hasanzada, and Dr. Singler, if this patient is yours, this is a high-grade slip, do you do the reduction or not?
I raised my hand. I'm just waiting to be called on.
Should I answer?
Adam,
Sorry,
you
Sean,
can
we have
just
to wait.
speak.
Did you raise your
name was not
hand?
mentioned.
You have the conch, Adam. You have the conch.
Yes, I mean that's a good question for the concept of reduction. Traditionally, we have taught that the higher the grade slip, really there's two different categories of slip: low grade and high grade. High grade is anything greater than 2, so anything more than about 50%. And then also you get a lumbosacral kyphosis too, whereby a grade 1 or a 2 slip. So if it takes anywhere from 0 to 50% of the sacrum, reduction risks of neurologic injury are probably low. I think this is in the higher grade category, whereby traditional teaching is reduction of this, not only anterior to posterior reduction, but reduction of the kyphosis, which is probably the more significant thing to reduce in these, just because you want to set them up for improved sagittal alignment in the long run. Is an increased risk of neurologic injury. I would probably try to get at least a partial reduction and more so a correction of that kyphosis. Young patient, active patient, she looks slender. I think that you could probably get a reduction. I would actually get a laying film on this. I know this is probably Dr. Shen's patient and he wouldn't consider anterior surgery, but I'd probably get a laying film and see if she reduces at all. Or over a bolster. Now you could say the MRI is a laying film, and I completely, you know, a supine film, and I completely agree with that. I'd probably try to go anterior and get a partial reduction. I think her symphysis is pretty low. I think you could probably take off that lip of 5 and get in there. I'd probably actually go to 4 because her 4-5 disc doesn't look great. So I'd do an anterior 4-to-1, get a partial reduction of 5-1, and then stabilize her posteriorly.
If you do the ALIF, you just put in the 1 screw or put in the 2 screws?
I put in only 1 if I want to achieve more of a reduction posteriorly, because I worry about binding that cage anteriorly. You know, I would be prepared if I can't get in there to do, you know, what's called a Bowman or a speed procedure. Again, this is getting in the weeds of spine surgery a little bit, but you can take a dowel, a fibular dowel. I can't point to it and you guys see, but essentially you drive it through the body of 5 into the sacrum and kind of transfix the lumbosacral junction with the traditional one's a fibular graft, but the problem is you don't get much correction with that. Dr. Shen's really talented in getting reduction posteriorly with these. For me, it's just a little bit tougher, and I think anterior surgery is a little easier for me. But anterior is not a chip shot either. I mean, it's a tough case regardless of how you do it. What do you think, Mead?
I think it's important to, I agree with you. All of the options you said is absolutely correct. And this is the dilemma we go as a spine surgeon. There are different options there, and each of us has different set of tools in our armatorium. The important is to know reduction has the benefit of creating the surface. You have 2 large surfaces over each other, increase the rate of fusion. It improves the overall, as you said, Scheimer, that alignment will be better, and then the focal alignment, the global alignment. Usually there's the school of thought is if the alignment is good, leave it alone, because there's a big problem with reducing the listhesis, especially high-grade spondylolisthesis, a nerve injury. The L5 nerve runs right into the foramen between the L5 and S1, and there's a lot of scar formation, and this nerve kind of get shortened over time, because this is a multiple year thing. This didn't happen yesterday, it happened over the years. When you pull on that, it could actually cause the nerve, the L5 nerve root, to be damaged, and the patient could end up having a foot drop. So there's a dilemma what to do. I would probably go from a back and try to not go to 4. I try to do just 5. I completely agree with you. There's a problem is 4 or 5. Just because this patient is 21, try to reduce the number of level involved. And distally, as Dr. Li said, there's a challenge because this is a doming and the sacral bone is not very good. So I might add pelvic fixation at ilium, at least temporarily, if not forever, just to give some fixation distally.
I'd probably get a hip MRI.
I would totally agree with and Dr. Scheimer that this is probably the most longest dilemma and the debate among the spine surgeon if to reduce or not to reduce high-grade spondy, because obviously you want to reduce because you can get the alignment better, especially the sagittal alignment, pelvic parameters, but the risk is huge. The risk of L5 nerve injury is huge, and to cut down the risk, probably a sacral dome osteotomy to shave off a little piece of sacrum at the top, that may help, but the decompression part is important. So it is a kind of very questionable decision for the surgeon to reduce or not, but I would favor reduction.
Dr. Shen, when you do the surgery, did you use neuromonitoring?
Yeah, that's a great question. I did not, but I would tell you free-flowing EMGs, free-running EMGs is very important in high-grade reductions because it can help tell you more real-time if you have too much of a stretch on the nerves. But I would tell you, I agree with you. I traditionally do not, as you guys know, use that, but that's a great question. I think everybody hit on everything that is worrisome, and that just speaks to the challenges of these high-grade slips. It's not just the reduction, it's the kyphosis, it's not just the nerves, it's the L5 nerve, it's the foot drop, and it's also getting fixation proximally and distally. So I think they've hit every single thing that I worried about as well.
That's some great discussion, a lot of pearls there. What I'd like to do is show some of the intraoperative imaging. So here we have an intraoperative O-arm spin, kind of confirmatory for pedicle screw placement. You can see that this is essentially a CT scan intraoperatively. It's a big C that kind of rolls into the patient, and then it completes into a big O, hence the O-arm, and gives us this image. Here you can see fixation from L4 to S1, and we can actually see in our post-ops that Dr. Shen did do a reduction and has some inner body grafts at both these levels.
Very nice.
We can see that that from her sagittal balance is much improved. When we compare them before and after, we get an improvement of about 4 centimeters of sagittal balance.
It's very important to say that these pedicles are also very dysplastic. Putting a pedicle screw is not that easy because especially L5 pedicle tends to be very small, and especially on a cranial caudal direction, so where the nerve root comes right underneath the L5 pedicle. And so it's very hard to get a good fixation. Dr. Shen did a great job here. It looks beautiful.
We have one more case here. This is a 50-year-old female, back and leg pain for 2 years. She has left leg pain.
Hey, pause for a second. We have a question. Mr. Turk is, Rob Turk is raising his hand. Do you have a question, Rob?
Yeah, thanks. I just had a quick question on this one in terms of the prognosis for this patient, especially with how active she was working at the zoo and things like that. What is her expected prognosis?
Yeah, that's a great question, Rob. So we follow the same philosophy every other fracture that you want to heal. 3 months is typically what I say of modified activity, and then you get you're looking for a sentinel sign for the bone to fuse, and then about 6 months I'll start letting them back for labor, back to unrestricted if her x-rays look good. So she's actually back now to full activity, so she's out far enough. So 3 months for modified, 6 months unrestricted if x-rays look good. Great question.
Awesome. Thanks, Dr. Shen. Sarah says hello, by the way.
Thomas said I as well.
So case 2, 50-year-old female, left leg pain, back pain as well. Her distribution of pain is from the left buttock to lateral thigh, posterior knee, and calf to the heel. Also with some right upper thigh pain near the hip. Pain is constant. She gets about 10 minutes of walking in until pain sets in. It's improved with lying down and worsened with bending forward, standing, and walking. No weakness, no numbness, pertinent medical history of fibromyalgia, GERD, hypertension, IBS, and mitral valve prolapse. She's non-smoker, and height, weight, BMI shown here. And she has some tenderness to palpation over the greater trochanter. Here are initial x-rays. Anyone want to pick out where her pathology is? Kind of more subtle than
Look like hips.
Do we have a hand raised? Hamid, you can't answer. You're an attending.
I was blaming it you, Winston. Looks like the hips are pain.
Well, I mean, she does have some FAI. I'd probably get a hip MRI and probably an injection, maybe surgery.
You know, that
That's a
actually,
good point.
that is a very good point. Dr.
Yes.
Goffney's
Who can look at that lateral X-ray and see what the instability is? Anybody in the crowd? All right.
This is a tough one. This is subtle.
Blow it up a little bit. Here we go, Rob Turk.
Yeah, I mean, I think I've seen L4, L5. But again, I mean, if it is there, it's very subtle, I would say. But that's
All right, good job, Rob. If you had to guess, is this an isthmic type or degenerative type based on location?
Ooh.
50-50 chance.
50-50.
based on location, I would say degenerative.
Very good. Nice job.
Very good.
Very good. Nice job, Rob.
And where are you from, Rob?
I'm from UC San Diego School of Medicine.
Awesome. So she had these flex X-rays, which show some instability at the L4-5 level. Next test that we obtained was an MRI. Here we can see that she has a good bit of facet arthritis. Both of these facet joints at the L4-5 level demonstrate effusions, and she has some constriction at the thecal sac. And then she didn't have any high-grade neural foraminal stenosis. Here are the paramedian views to demonstrate that. And in summary, we have a 50-year-old female, multiple medical comorbidities, back greater than leg pain, left greater than right leg pain in regards to the leg realm, and then BMI of 37. I'd like to ask the attendings what thoughts they have.
This is back pain, huh?
Yeah, so
Most of the back pain.
so
What do you do, Dr. Shen?
So first of all joking aside, I think Dr. Gwathmey's point is well taken. We share a lot of patients with the hand surgeons and a lot of patients with the joints and sports patients. So you should always, even when you're on the spine surface, you should always think about peripheral compression and hip and knee pathology and vice versa. So that's something to take. The other thing is, I think this is unstable slip. So while there is back pain component, we tend to stay away from surgery for back pain. This is an instability one. I bet a lot of it's transitional pain. So I do think a decompression and a stabilization is what I would favor because it does reduce on extension on the MR.
I think, Francis, we can go along to show what I did, and we can.
So here's the post-operative images, and what essentially happened was posterior instrumentation with robot assistance at L4 to 5 and an OLIF, oblique lumbar interbody fusion. The interesting part of this is that it was done in a single position where the patient was positioned laterally. So here you can see posterior and anterior. We have the O-arm in the background. The head is located here just for additional orientation. Here you can see that Dr. Li is utilizing the robot to guide the pedicle screws into the appropriate locations percutaneously. We have a tracking device here that computes the patient's O-arm CT scan to correctly guide the pedicle screws. Some other shots showing that there's these wires that allow you to place those screws accurately. And then the anterior portion is the OLIF, which is a retroperitoneal approach. Here we use sequential cannulas to allow access to the disc space. Now we're using that CT GPS essentially to drive that inner body graft into the appropriate disc space after removing the disc material.
I just want to highlight that this is what they call a single position lateral. Francis, you said it, but this means that patient had both access to the back and the front through a single incision, which is really something that's very few of these are done around the country. And Dr. Li and some of my other partners are doing these more and more standardly. So small incision, single position, it's really a game changer for our patients. So it's excellent.
Thomas, let's give your presentation.
Hey, Joshua, this is awesome stuff, my friend. I mean, this is, Dr. Chhabra and I are having a side text, and both of us want to get back in the spine somehow. So great, really great.
I'm ready to be the next spine fellow, guys. I can be the chair and the spine fellow at the same time. It would be awesome.
What we should have done is we should have just shown spine clinic, and that would have really gotten.
I'm worried about duty hour violations.
Well, that was awesome, guys. So we're going to move on to Dr. Moran, one of our PGY-2s. He's going to talk about just stuff after, after you finish all those awesome spine surgeries, what do you want to do?
Hey, Winston, before we do that, can I just say a few things?
Yeah, go ahead.
Before this, I just want to thank our spine division, or ortho spine division, for the presentations. They were really fantastic. And I hope that all our virtual rotators can see the strength of this ortho spine division here at UVA and the cutting edge technology they use, and what phenomenal educators they are, led by their division chief, Dr. Shen. Dr. Shen and I go way back. We were residents together and came on faculty together. So we spent a long time together at UVA, and I can tell you the commitment from the spine division, ortho spine division, represents the commitment from all the faculty. So I hope that all of you are seeing not only the strength of each of our divisions, the talented faculty, but also their commitment to education. And you can see, you hopefully are seeing that with every week and every divisional presentation. So, but the spine team tonight really knocked it out of the park. So congratulations, guy. That was a really phenomenal presentation about the division, and also the cutting edge work that you're doing. So congratulations, and thanks for everything you do for our department and for our education program.
Stuff. Thanks, Dr. Chhabra. All right, Thomas, what do you got?
All right, I'm going to bring us home. So I'm going to give a kind of a quick and comprehensive look at what resident life is like at UVA. I'll start with some of the more mundane stuff about becoming a surgeon, academic life here at the University of Virginia. Then I'll segue into community service, talk about some of the what I feel like is one of the highlights of the program here is the fellowship amongst the residents. And then I'll touch on some of the highlights of Charlottesville itself, and what we like to do when we're outside of the hospital. So for starters, obviously there's a reason why all of us are here at the University of Virginia. It's to become proficient and competent surgeons. And here you have a couple pictures of us in some different clinical settings. In the top left, you have Kara Thorne performing what looks like some sort of hand procedure. We definitely get in the operating room early on, get a lot of experience, working with the faculty. There's a lot of direct mentorship that takes place. And like I said, it starts from really day one. We take advantage of our soft tissue lab. At the bottom, you have one of our graduated chief residents from last year, Aaron Casp. Looks like he's doing an arthroscopy simulator. So there's a lot of opportunities to get experience operatively outside of the actual OR itself. Quickly touch on academic life, which I think is pretty robust here at the University of Virginia. We have two of our residents. One is our graduate chief, Siraj, and then one of our current fourth year residents, Matt Deasy, and this is them at the AAOS meeting. At UVA, we're pretty active in research, and there's a really strong infrastructure in place to be accomplished, academically. This is a slide I stole from one of Dr. Chhabra's PowerPoints about our research achievements in the year of 2018. I couldn't find a more updated edition, but I can only imagine that this has continued to improve over time. In every division, we have clinical research coordinators that help with IRBs, help us to get studies approved, and help keep things moving along. we are also expected to be leaders in the hospital as well as start to be leaders in the community. And we're pushed from day one to become volunteers at the Charlottesville Free Clinic. There's an orthopedics night that takes place monthly that we participate in. And then one of the really cool opportunities we have to serve the community is by serving as one of the team physicians for one of the local high school football teams. Unfortunately, that may not be happening this year just because of COVID and the Virginia High School Athletics League not holding competitions, but something that in usual years often takes place. All these community service events usually followed by us getting together afterwards for a couple of drinks, which is what's pictured below. I'll start to segue into the fun stuff. So, this is one of the residency programs, and I think this comes up at pretty much every single one of the interviews I went on, but the question's always asked, like, is this a place where, residents hang out, or is this a place where everyone is kind of co-workers and then goes home, goes their separate ways? And I think these pictures right here illustrate the fact that, we're a really close-knit group. There's become a pretty strong contingency that bikes together regularly on the weekends. You have Pearson, Matt DC again, pictured in the top left, looks like they're on a bike ride. Dr. Chabra hosts a softball game every year, usually around graduation time. Unfortunately, again, this last year that didn't take place, but usually it's something that happens and something that everyone really looks forward to. And then the bottom, that looks like one of our beginning of year cookouts taking place at Dr. Gwathmey's house. So we all look for reasons to get together and spend time with one another. Another picture, demonstrating a group of residents together. Top left is one of our local wineries, Mount Ida, which is a really spectacular place. And I think that's something that really makes Charlottesville stand out. And I think the area is really known for. I believe the picture on the top right's the same thing taking place at another one of the local wineries. But again, emphasizing the same point that we really do like to spend some time together with one another outside of the hospital. Quick office meme. But I think this is a place where we do work hard, play hard. We're outside of the hospital. We're kind of all looking for things to do, ways to have fun. So the question kind of comes up, what is there to do outside of the hospital in Charlottesville? I think that one of the real strengths of Charlottesville is that it's kind of this small community that has the amenities of a much larger city. And I think that's something that is frequently said about Charlottesville. I think one of the other real special things about it is that it's you have close access to restaurants, to shopping, to all those things, but then you're also just about 15 minutes away from some of the great outdoors. You're just a 15-minute drive from some pretty spectacular hikes up on the Skyline Drive and up in the Shenandoah National Park, and those are kind of pictured here in this slide. Of course, UVA sports is something that we're really passionate about at the University of Virginia. We're really proud of our University of Virginia men's basketball team that I'm going to go ahead and say still reigning national champions since the actual tournament didn't take place this last year. And our football team's really coming along strong. And we were division champs this last year in the ACC. Ended up playing in the ACC title game against Clemson. Two, I think, pretty cool photos that I stumbled across when I was working on this presentation. But the picture on the left, you actually have LeBron James if you look closely. And then the UVA ortho logo is highlighted pretty prominently. And then, of course, Dr. Chabra on the right holding the national championship trophy from 2 years ago. There's a pretty strong live music scene here in Charlottesville. I believe the picture on the left was taken at the Jefferson Theater, which is one of our local venues. Attracts some pretty strong musical artists. And then on the right is a flyer from a concert event that took place in 2017 that was just absolutely star-studded. Dave Matthews Band, Justin Timberlake, Ariana Grande, really some of the bigger names in music right now. And that took place at the football stadium. So a number of different venues. There's kind of always some really strong acts that are coming through Charlottesville, and it keeps things fun and keeps things interesting. Of course, the downtown in Charlottesville is a pretty lively spot where we all get together, after work on weekends. This is kind of one of the main thoroughfares. Pictured as one of the bars and restaurants, Commonwealth and Sky Bar. But there's of course a number of different selections, and you know, I've been here in Charlottesville for 5 years now, and you know, I'm still making lists of places that I want to go and things I want to do downtown. So definitely haven't touched them all yet. I think Charlottesville is really known for its food options, and pictured are a couple of my personal favorites. Lampo is like a Neapolitan pizza, and Tavola is an Italian restaurant, and then another one of my current favorites is Marie Bet, which is a coffee shop, and I've started going there most weekends. But a number of different selections, and if we were to go around the room here, everyone would have their own favorites. You'd probably end up hearing a bunch of different selections. I think it's actually really unfortunate that we can't all have you guys come through as away rotators and get to check some of these places out on your own. Next, I kind of alluded to this when I was showing the pictures from earlier, but Charlottesville and the surrounding areas become really, prominently known for its wineries and its breweries. There's a strip called the Nelson 151 that has just almost an endless number of breweries, and pictured here some of my personal favorites. King Family in the top left, and the bottom is Three Notch, which I would go out on a limb and say is one of our flagship breweries, but definitely no shortage of places to eat and to go out and grab drinks with friends, family. Again, tons of outdoor activities, and I think that's again one of the things that makes Charlottesville really special. If you're into golf, there's tons of different options. Birdwood is pictured in the top left. We're really close to the Wintergreen Resort, which is in the bottom left. It's like a 4-season resort. There's golf, there's skiing. Then in the top right is Beaver Creek, which is one of the local, waterways, lakes. You can get out with kayaks, canoes, fish, if that's what you're interested in. And then Lake Anna in the bottom right. So to finish this off and take us home, when I was trying to figure out a way to demonstrate Charlottesville to those of you that haven't had the opportunity to spend any time here, I actually stumbled across this quick 2-minute video. So I think I'll play this just to take us home.
This is a place where the world spins as it should. It changes with the world. And in some cases, it is changing the world.
We could not see your video.
Can't see it? We'll try it again.
Try sharing your
You got to share your other screen.
This is a place where the world spins as it should. It changes with the world. And in some cases, it is changing the world.
The university feels like a major part of this community in town. There is this separation, but also togetherness.
The beauty of the place and the intricacy and the complexity of it struck me.
There are a lot of features of a metropolitan place that we have here in Charlottesville, but without some of the metropolitan headaches. Activities outside with friends and family, being able to eat at great restaurants, hang out at coffee houses, attend great art events.
The cultural scene here is way bigger than a town this size should have. There's always something happening. The riches of that are fantastic.
Charlottesville is literally nestled at the foot of the Blue Ridge. Any scale that you want to be getting outside and seeing incredible sights, we're in a place that can facilitate that.
The beauty of the outdoors around here is what drew me to Charlottesville, but the people are what made me stay. There are people that care about you, your family, and care about your goals and hopes and dreams.
You want to be part of a community that is constantly evolving, not in a rush, but gradually, so you can piece the place together and make it work for you.
I think Charlottesville has a way of drawing people back.
It's home. It becomes home pretty rapidly.
I have a connection to neighbors and friends that I've not had in any other city I've lived in.
After a while, you wonder how you could have lived anywhere else.
I remember saying this to myself after my first year. I'm never going to take this place for granted. I'm never going to take for granted what I'm seeing. It's just beautiful.
All right.
Thomas, that was awesome, my friend. Great stuff. Well, it's 9 o'clock on the dot. The spine team efficient as usual. Usually I think spine team, operating until 2 o'clock in the morning. So 9 o'clock's an early night for you guys. You guys have some cases posted. Look for later, Dr. Shen.
Dr. Shen's elective time starts now.
That's right. We're good tonight. I blocked tonight out for you guys and our visiting virtual students. So we're all good.
Winston, do you have a radio station there?
So I have my little speaker thing here, you see?
Yeah.
Oh.
Yeah, I don't know. My old speaker wasn't really picking up my voice very well. I want to hear you how beautiful my voice is. I do some concerts too. So
Maybe I should buy that microphone. It might help with my accent.
Yeah, I'm not sure it works for that, Hamid. You can try. Well, good. So I hope you guys recognize sort of the investment we have in our educational process here. I mean, each one of these meetings we've had basically the entire faculty from that division, the spine division, all 5 faculty here together. So I hope, to me, honestly, I actually paid attention and enjoyed that a lot, Dr. Shen and Dr. Li and Francis. That was really nice stuff. So we'll keep going. Next week we'll have the total joints team go, and I really, really want you guys to understand what you have coming your way. Dr. Thomas Brown will be giving a talk, and I've never actually heard him give a talk before, and he is an unbelievably funny and smart and sarcastic guy, and I just can't wait to hear what he has to say. So I hope you guys tune in next week. I think it's gonna be a lot of fun. We're also going to talk about fellowship and mentorship. So Max Hogger, one of our PGY-5 residents, is going to talk about, 1, the mentorship program we have here at UVA, and 2, just kind of the process of choosing and then getting into a fellowship. So I think that'll be really interesting too. We'll close it out the following week with the trauma division, and then we'll have a resident-only forum there at the very, very end of this. So again, I will send out an email about how to meet up with me and Dr. Bachman individually. And then after that, we'll hope to see you guys during the interview process. So Dr. Shen, Dr. Li, Dr. Moran, Dr. Bustos, Dr. Hassanzada, Dr. Singla, thank you, and Dr. Schreiber, thank you guys so much. That was awesome.
Thank you all.
Thanks, everybody. Good night.
See you later.